allergy. We're going to touch on definitions, then we'll look at classifications of food allergy, look at IgE versus non-IgE reactions, and how to diagnose these patients and how to manage them afterwards. It's quite important to understand the definitions so that you'd be able to diagnose a patient that you suspect has food allergy. So food sensitization just means that a patient has IgE antibodies against a certain food. Reactivity without any symptoms when the patient ingests it. Get exposure. Food intolerance is not immune mediated. So who's at risk of food allergy? Patients that are atopic, patients with asthma and other allergic diseases, children with moderate to severe atopic dermatitis appear to have approximately 35% risk of food allergy. However, I would like to highlight that atopic dermatitis does not cause food allergy. Now let's look at the different classifications of adverse reactions to food. We've got the toxic and non-toxic. Under non-toxic, there are those that are mediated by the immune system and those that are not mediated by the immune system. Those that are not mediated by the immune system are food intolerances, such as lactose intolerance. They can be enzymatic, pharmacological, or other. Now, reactions that are mediated by the immune system are called food allergy, and they could either be IgE mediated or non-IgE mediated. IgE mediated commonly present within minutes to hours. So a patient would ingest peanut, for example, and within 2 hours they already have clinical manifestation of symptoms. Symptoms vary from skin symptoms such as acute urticaria or angioedema. I would like to highlight that patients with chronic urticaria do not equal to food allergy. Gastrointestinal symptoms can present as vomiting, severe abdominal cramps, diarrhea, and itching of the lip. And that's just a picture of, on the right-hand side, one of my patients with clear urticaria, and that I got off the internet with urticaria and lip angioedema. Respiratory manifestation can be from upper respiratory or lower respiratory. With upper respiratory, they can have symptoms such as sneezing, itchy nose, itchy eyes, congested and runny nose, to severe lower respiratory symptoms such as laryngeal angioedema, bronchospasms, coughing, or wheezing. Systemic anaphylaxis, Dr. Hawadin has touched on it, which is the most severe and life-threatening reaction involving multiple systems. Non-IgE food reactions present later on, so they are delayed reactions that happen after 2 hours, up to 24 hours, or even weeks after ingesting a particular food that a patient is allergic to. Inflammation is commonly seen on the skin or the gastrointestinal symptoms such as delayed eczema, delayed vomiting and diarrhea. In FPIES, a child who's allergic to cow's milk protein allergy might have vomiting and diarrhea that's delayed 3 hours after ingesting cow's milk. They can have loose or frequent bowel actions, blood in the stools or mucus in the stools, can be an irritable and unsettled infant. Common food allergens are milk, wheat, egg, soybean, peanut, tree nut, shellfish, and fish. Now, the common food allergens in children are cow's milk, egg, peanut, tree nut, wheat, soy, fish, shellfish, and now sesame. In adults, the most common food allergens are peanut, tree nut, sesame seed, seafood, and also fruits and vegetables. So where do we start? How do we begin when you see a patient that's in your consulting room and you're suspecting that they have food allergy? The most important thing to do is to take a detailed history. So you want to know about the feeding history at birth. Was this child breastfed? Was the child formula fed, or is it mixed feeding? If it's formula, you would like to know if they're feeding on cow's milk or soy. You would also like to know the age of solid introduction. Is. So the kind of questions that you would ask would be, what food do you suspect caused the reaction? How much of the suspected food did you eat? Because if you have a child that just ate minute amount of a certain food that you're suspecting and had severe reaction, you already know that you're dealing with a high risk infant. And you want to know what other foods were eaten at the time of reaction. If the patient actually knows all the ingredients in the food product, they might not even know at the time. And you want to know, how was the food prepared and served? Was it fried? Was it baked? Was it served with other food? Perhaps there was contamination. So you just want to have a clear picture of what could be, the suspect food. More questions to ask would be, what was the time between eating the food and manifestation of the symptoms? Because remember, I told you with IgE happens within minutes to 2 hours, and with non-IgE reactions are delayed. There has to be reproducibility of symptoms. So you want to ask the patient if the symptoms occur on every exposure to that particular food. Is there a history of avoiding or refusing to eat the suspected food in the infant? Will the infant or the baby just say, no, keep refusing the food without any particular reason? Is the child refusing the food? Never re-accepted that particular food. In diagnosing a child or an adult with food allergy, a detailed medical history is of utmost importance. And then you can move on to other tests, such as skin prick tests or specific IgE in blood. Now, serum-specific IgE testing is performed at least 4 to 6 weeks after the reaction. The golden standard for diagnosis is an oral food challenge. This should be done by somebody who's experienced in a safe environment where if the resuscitation is needed, the doctor or the clinician is actually ready for it. There are clear protocols of how to do an oral food challenge, and if you suspect a certain food, it's given in small incremental doses to elicit symptoms. Okay, now let's talk more about testing. I'd like to just highlight that when you test for a specific food, for example, peanut, that's an allergen. Do you realize that there are components, meaning it can be broken down into different components? And so it's important when you test that you also check for components to test if there is true food allergy or just cross-reactivity. That pinpoints to that specific problem that may be causing the allergic symptoms. It can be useful to estimate a patient's level of risk. For example, in patients that have oral allergy syndrome, it might be that they are sensitized to pollen. However, when they eat a certain fruit or even a certain or even peanut, they get cross-reactivity and experience local symptoms. Peanut allergy is associated with other legumes. So when you get a patient that you suspect is allergic to peanut, you want to ask about other legumes. You want to ask, do they tolerate chickpeas, lentils, beans, soya? Do they tolerate tree nuts? or sesame seed because of cross-reactivity. And the important component to test for true food allergy there in peanut is RH2. There are other components, but this is the common component that we use to test for peanut allergy. Allergic to a certain fish, there is mono sensitivity. However, commonly there's cross-reactivity. And we must be aware that fish is heat stable. And the component to test for true fish allergy is parvalbumin. There are fish allergy mimics, meaning that a patient is not having true fish allergy, and that's why I say there has to be reproducibility of symptoms. Whenever a patient is exposed to that particular food, they have to have symptoms. Scromboid fish poisoning is another fish allergy mimic that occurs if a fish is ingested that's not that's not stored in a in good temperature, so spoiled fish, and it can produce symptoms such as flushing, urticaria, vomiting, and diarrhea that can be found in uncooked fish, and it can produce symptoms that are similar to anaphylaxis, and some patients are actually sensitized to anisakis. So where there is no true food allergy, if the parvalbumin comes back negative, you might want to test for anisakis. Egg allergy. In egg allergy, egg white is the culprit, and there's cross-reactivity with other bed eggs such as duck. Having an allergy to egg is associated with increased risk of peanut and other food allergies, atopic dermatitis, and later on development of asthma. Patients that are allergic to ovomucoid, which is a component that is heat stable, will have reactions to egg in any form. So when we go back to the history and we said you have to ask how the food was prepared. So in patients that are positive to ovomucoid or allergic to ovomucoid, they would have reactions to either fried egg, fresh egg, or even baked egg in the form of muffins and so on. However, patients that are allergic to overalbumin component in egg will tolerate baked egg, but react to cooked egg or fresh egg. In cow's milk allergy, the components to consider are casein and whey, and 80% of patients are allergic to casein. There's a high degree of cross-reactivity between cow, goat's milk, and other sheep and mare. So when you do suspect a patient with cow milk, you would also like to have them, you'd also like to ask about reactions to goat or sheep or mare, so that when you advise about avoidance, they should be aware that there's cross-reactivity between the other goats, the other milk. The clinical relevance of testing for casein and whey is that casein is also heat stable. So a patient that's allergic to casein would have reaction regardless of if the cow's milk was heated or not. Ultra heated milk. Patients that are allergic to casein will not tolerate ultra-heated milk or fresh milk. Ultra-heated milk and have allergic reactions to fresh milk. And 20% of them are also allergic to beef. And 93% of children that are allergic to beef are also allergic to cow's milk. Alpha-Gal and allergy or mammalian meat allergy is it's a new kind of allergy that's been identified where patients present with delayed symptoms, and it's not upon exposure, every exposure to red meat. Okay, so these patients usually report reactions to any kind of mammalian meat, be it cow, pork, lamb, and so on, any other kind of mammalian meat, and they usually present later on, 3 to 5 hours later on. So this is an IgE-mediated reaction. Did not typically present with delayed reaction. We had patients that presented within 2 hours, and I think the earliest was 45 minutes. So there is still a lot of research that's going on to actually understand the pathomechanisms behind it. So when would you refer a patient to do an oral food challenge? As we've said, it's the gold standard for diagnosis. So if you want to establish if a patient that is allergic is actually becoming tolerant, if they're outgrowing the allergy, an oral food challenge can identify or clarify the status of allergy, which versus a patient that has some anxiety around a particular food. So it can tell you the difference between a patient that's anxious because they have a sibling that has food allergy versus a patient that has true food allergy. It's not performed in patients that have had a clear history of anaphylactic reaction or those that with unstable asthma. Oral allergy syndrome is it's an allergy that's quite common in adults with allergic rhinitis. So they're sensitized to aero allergen when then they eat a certain food. There's cross-reactivity and manifestation of local symptoms to a particular food. For example, the example that I gave earlier, that patients that are allergic to pollen with allergic rhinitis might eat a certain fruit and get local symptoms such as itch or tingling of the lips or tingling of the tongue or roof of the mouth, local symptoms. However, those patients may tolerate fruits or vegetables in cooked form. Other food reactions are non-steroidal anti-inflammatory drugs induced food allergy, or patients that are allergic to a certain food only after exercise. So you'd find a patient that can tolerate a certain food like prawns, and suddenly when they exercise, they have anaphylaxis to that food. I recently had a 13-month-old who was exclusively breastfed for 6 months, and the mom had to go back to work. So she then decided to introduce at 6 months cow's milk formula, an egg, and the child vomited immediately. So this was a clear IgE-mediated reaction. She was advised to avoid all the other allergenic foods because there was quite a fright around the child having allergy to all the other allergenic food based on the specific IgE blood results. The mom was quite anxious, very young mom, about what to feed. Very restricted. And so she was referred to me, and I looked at the blood results, and those are the blood results that are reflecting with reference on the right-hand side. So she had high cow's milk protein allergy of 79, wheat of 48, soy of 38.5, peanut of 24, egg of 81, and fish of 0.22. So at this time, it was just general testing and no component tests were done. And the mom was advised that to use extensively hydrolyzed formula, and she complained that it's quite expensive. She can't afford it. Because of a recent history to cow's milk formula and egg, I performed an oral food challenge to other foods. Okay, so the child was negative to wheat, and I could happily tell the mom to feed wheat. Option. However, this child had so I then introduced soy formula and advised the mom to start introducing other foods, including wheat, fish, and baked cow's milk. Think about peanut immunotherapy as an option. So I'm now reviewing him on a yearly basis, and we're just monitoring specific IgEs to peanuts and egg to see when it would be a good time for introduction of the food. Because remember, I said oral food challenge can also be used to determine tolerance. Natural cost of this food is that by the time patients are 16 years, they would have outgrown their allergy to milk or egg. By the age of 10 years, so earlier on, they would have outgrown their allergy to soy. And by 12 years, they would have outgrown their allergy to wheat, so much quicker. However, with peanut, tree nut, fish, and shellfish, the allergy persists longer. And in only a few, 20% of the patients have resolution of peanut allergy and only 10% to tree nut allergy. Dr. Hawadin touched on how to manage a patient with reactions, so I will skip that. The non-medical management would be to spend time with the patient, because usually if it's the mom, the caregiver, they're quite anxious about the food. If it's an adult, they're also very anxious. You really want to just educate them, teach them about food labeling, regularly monitor a child if they're growing well, what's their nutritional status, work together with a dietitian. Highly restricted diets obviously affect nutritional status and results in failure to thrive. So you want to just avoid advising patients to avoid certain food because it might have an impact on their growth, unless you're quite confident that it is food allergy, not just based on blood results. You can refer to an allergist if you suspect an IgE or non-IgE mediated food allergy. If you suspect that there is food allergy, even though the specific IgE tests or skin pricks are negative. If you have a patient with multiple food allergy, high risk, they need to be assessed by an allergist. In patients that have moderate to severe eczema, where the parents suspect that they may have food allergy, where there's confirmed food allergy with asthma, to other fruits such as banana, kiwi, chestnut, and avocado. My key message is that take history, take your time, sit down with your patient and take history. History is your tool to help you make diagnosis of food allergy before jumping to tests. And that food sensitization is not always associated to food allergies. So when you have positive specific IgEs, it does not mean that the child is definitely allergic. Level